plays, the connected plays may become the new TPA in the very near future. So here's, I'm going to show you two cases, and then I'm going to talk about these two cases at the end after we've had some background information and to see what we would do with these two cases. So here's a 62-year-old woman, baseline MRS, so completely normal, no impairments, no disability. She presents with an acute right-sided hemiparesis, last seen normal 7 hours ago. So until recently, well beyond any therapeutic window. 6 hours is the last thing I heard about for endovascular clot retrieval. She, however, comes to the regional stroke center and actually could show up in any one of our thrombolysis sites. She'll undergo a CT perfusion, CT angiography, and it shows a left middle cerebral artery occlusion, an M1, so the first division of the middle cerebral artery. Her aspect score, the Alberta Stroke Program early CT score, is 9, which means that there's very little early ischemic change. And she has rapid perfusion imaging, which I'll talk about what that is. The question is, should she receive TPA and EVT? Should she receive tenecteplase and EVT, or should she go right to EVT? So if she's sitting in our ER here, maybe the lab's ready, we should go right to EVT. Or is she really eligible for anything since it's been 7 hours since her last seen well? Case number 2 is a 70-year-old man whose baseline MRS is 0, again, completely normal and independent. Acute left-sided weakness, NIH 10. To get 10, you have to have a plegic arm, plegic leg, and a significant facial weakness gives you 10 points. Last seen normal was 6 hours ago. So in fact, he's within the traditional endovascular clot retrieval window of 6 hours. He has a CT, and we managed to call MR, and MR actually does an MRI on him acutely and shows no area of infarction on either CT or MR. He has a CT angiogram done, and it shows no large vessel occlusion. What do we do with this? Someone who obviously looks like they have a stroke 6 hours ago. There's no large vessel occlusion. There's nothing to go after with the clot retrieval. And his CT and MRI show no areas of infarction. Is he still eligible for TPA? Well, it's 6 hours. EVT, but there's nothing to pull out. Tenecteplase, TNK, A and B, all of the above, none of the above? I thought it was straightforward. So stroke by the numbers. So just a backgrounder. I mean, it's one of the things that I get sort of as a comment from my wife at home when I run out the house in the middle of the night is not go save a life, but go save some function. And so that one thing I think of all the medical disorders that we deal with, stroke is the one. Stroke, traumatic brain injury, MS, all the brain disorders. The one thing about them is it's not about life and death, living or dying. It's about impairment, loss of function, and loss of activity. And so the one thing that we're always trying to do with stroke is trying to prevent decreased impairment to preserve all the other things in somebody. It's not just about death and dying. So I grew up through all these eras. I sort of started in the late 70s. That isn't that long ago. I was talking to one of my residents today. The first CT scan of the brain that could actually look in the brain without actually opening the skull in Canada was in 1976. Was the first time we could actually look at the brain and know if in the brain there was hemorrhage or infarction. And nothing really happened until not really much improvement in hyperacute stroke care. There was lots of activity into the 1980s. The mouse is there, and there were a lot of mouse models for stroke care. And we could show that you could actually occlude a vessel, and over the next 3 hours, if you gave different drugs and things, you could actually decrease the amount of brain injury. But we've never been able to, as yet, even today, translate protecting the brain with drugs that has a stroke in humans. We could not have been able to do that. But the situation changed, and it took from 70s, 80s. During this time, we had aspirin for prevention. We had endarterectomy in the early 1990s for prevention. We had anticoagulants for prevention. We had nothing for acute treatment of stroke. If somebody came in with a stroke, it wasn't until 1995 when thrombolysis occurred. And thrombolysis is when we started talking about time is brain. That what this graph shows is thrombolysis with TPA, is that if you can treat somebody within 90 minutes of the onset to treatment time, OTT, onset to treatment time, that you would have to only treat 4 to 5 people within 90 minutes of the start of their stroke to make one person completely independent. If you wait until 3 hours, which is here, from their onset of the stroke to when you treat them with TPA, you have to treat 9 people to leave one independent. And it goes on like that. And by the time you hit beyond the 4.5 hour mark, you start having no benefit from giving thrombolysis. And in fact, if you have another curve here that had the risk of hemorrhage into the brain from giving thrombolysis, you would see that that goes up as this goes down. So time is brain. And we've been trying to decrease our door needle times to 30 minutes as a goal because of this. I like this. This graph is one of my favorite graphs when it talks to thrombolysis with TPA. And this is what does that number needed to treat kind of mean in sort of a more sort of visual kind of way. What it means is that if you treat somebody with TPA within 3 hours of their stroke onset, you take 100 people, there are 100 little people here. And if you treat 100 people on average with TPA, you will make all these people in green better than they would normally be without treatment. All these people who are not colored will have the same result as if they were not treated. There's a downside to TPA, and there will be 3 plus a few people on average out of 100 that will have some hemorrhage as a complication of the TPA. When you look at this whole graph, there are many more green people who benefit substantially from treatment, and a lot of people won't be harmed or benefited, and there will be some that'll be harmed. Some people who don't deal with thrombolysis really worry about this small group, but I like to think of this large group of benefit of individuals given a chance to reduce their impairment. It's not about life and death. Remember, it's about reducing impairment. And this graph is also useful too. So if you delay and drag your feet and don't treat rapidly, this is what happens. It's almost half the number of people benefit from treatment, and there's still this risk of bleeding. So the idea is to push this that way. And then Dr. Hawks gave us a detailed review of endovascular clot retrieval, pulling the clots out. This is 1995, and it took 20 years, 2015, to get to here, where we now pull out clots out of the middle cerebral artery with stent retrievers. And this is this treatment, not only did it change what we give and what we treat with, but it also changed all the imaging that we had to do. In the pre-endovascular clot retrieval days, all you needed was a plain CT scan of the brain. And it was, in fact, we were told sometimes to decrease our door to needle time, to treat more people, avoid doing this fancy imaging. before giving TPA because it decreases your door to needle time. But then with the advent of clot retrieval, we start doing CT angiography, and we also start doing blood flow imaging. And before the recent advancements, which I'll talk about in rapid imaging and that, the other thing that we did is we started doing CT angiography so that all of a sudden physicians had to be not only able to look at a simple scan of the brain, which has only 25 slices in it. They had to be able to review a CT angiogram, which has 300 to 400 pictures in three-dimensional view to look for occlusions and the vascular anatomy. And there's also a set of pictures where they looked at this multi-phase CTA, where we did a snapshot of the brain when the dye went through. We did a snapshot of the brain 10 seconds later and a snapshot of the brain 20 seconds later approximately to see what the blood flow was doing over time. And with that, we decided, in fact, if somebody should go on to endovascular clot retrieval within the 6-hour window. And
yes.
Yes?
I have one question before you get too far in about EVT. Is there any way to predict which patients may bleed after TPA?
If they have contraindications to treatment, would be the biggest one. So, I mean, there's a long list of inclusion criteria, exclusion criteria. So that one of the things that was clearly shown in the early trials with TPA is that you have to follow the recipe very strictly because you will cause